The following podcast is part of a certified educational activity titled PrEP Personalization in Key Populations, Understanding Unique Needs and Challenges in PrEP Provision. Access the entire activity and complete the post-test at peerview.com/CNQ860. Downloadable slides and practice aids are also available.
Hi, and welcome. My name is Meredith Clement. I'm an associate professor at Louisiana State University Health Sciences Center here in New Orleans. And today we're going to talk about PrEP personalization in key populations, understanding unique needs and challenges in PrEP prevention. And so, to lay out our goals for the day, first, we want to augment your knowledge of stigma and barriers to PrEP uptake in key populations. We want to equip you with strategies for applying recent evidence and guideline recommendations for PrEP initiation. And finally, provide guidance on integrating person centric approaches to PrEP care. All right, so first let's talk about PrEP related stigma. So, stigma is defined as a personal attribute or characteristic that confers a negative judgment or value onto the individual. And when we talk about PrEP related stigma, I think it's important to think about what it is and what it does. So, first, in terms of what PrEP is, it contains medication used to treat HIV. And so, therefore, it can be stigmatized by association. So that means that current and potential PrEP users may be concerned that others think that they have HIV, or the PrEP users may worry that they will be perceived as engaging in behaviors that are linked to HIV acquisition. And so we see this a lot in our clinic that folks have these concerns. The other thing we know what PrEP does, it's very effective in preventing against HIV acquisition, but we have to be careful in our language around PrEP. So, when we talk about literature and guidelines that describe PrEP as an intervention for people at very high risk of HIV acquisition, we have to realize that that is stigmatizing. In general, I don't like to use the term risk when I talk about HIV. I say people who could benefit from PrEP or PrEP candidates, generally speaking. But when we start talking about risk, and especially the term risky, that is particularly stigmatizing and it alienates potential PrEP candidates. Okay, so specifically, let's spend a minute talking about PrEP uptake and adherence barriers in Black and Hispanic transgender women in Southern California. And these data come from a couple of studies that have specifically looked at these populations. We know that Black and Hispanic transgender women are disproportionately affected by HIV. There are high rates of HIV diagnoses in both of these groups. So for Black transgender women, that's a rate of 41% of HIV in that population. And for Hispanic transgender women, a rate of 39% HIV. Those are prevalence rates. And so because of those high rates, we know that Black and Hispanic transgender women can benefit from PrEP use, but there are barriers that affect both kind of initiation or that access step, and then also persistence. Stigma is a big one, as we're discussing, but then there are also negative community opinions about PrEP use, negative experience in healthcare settings. I think we know this, particularly for our transgender patients. They often receive treatment at care facilities that's not consistent with the way we would want ourselves to be treated because of the stigma, the prejudice, judgment, etc. And then transgender folks may have individual concerns, so that apply kind of maybe to some but not all. So we're talking about costs, substance use, and then drug-drug interactions. Okay, so in terms of types of stigma associated with PrEP use, we can talk about several different kinds of stigma. So, individual stigma, that has to do with distrust in PrEP efficacy, potentially internalized promiscuity or homonegativity. And these are kind of, again, are these internalized. This internalized stigma that folks may or may not feel. Then, in terms of relationships, there's also interpersonal stigma. So, again, the promiscuity comes in, but it's perceived risk, promotion, or promiscuity HIV-related stigma can play a role here, and then there can be a negative impact on romantic relationships. There's also community level stigma, that's anticipated homophobic reactions from others. And then finally, institutional related stigma or institutional factors that play a role in this stigma. And there are high levels of medical mistrust or distrust among these populations. And as we mentioned earlier, there can be discrimination by healthcare providers. And so it's those lived experience of transgender folks that leads them to have this mistrust or distrust. Also, historical treatment of their populations, systemic racism, all these things kind of play a role in different types of stigma that we see. Also, distrust in government or pharmaceutical companies can also play a role here. Okay. For structural barriers to PrEP use in young sexual minority men, there are cross sectional data from a cohort study that was conducted among gay, bisexual, and other men who have sex with men, or what we call sexual minority men. Within this cohort study, 31% identified as Hispanic, 26% identified as Black. In this study, although 100% were aware of PrEP, only 14% had ever used PrEP. And in this study, the main structural barriers that were identified were healthcare access. And so that's the ability to see a provider regularly for prescriptions, comfort in discussing one's sex life with a healthcare provider. And as we discussed, we know stigma from healthcare providers can pose a significant barrier to PrEP, both access or initiation and persistence. And then also counseling support for one's sexual activity for PrEP use and medication logistics, such as daily reminders. So let's talk for a minute now about barriers and disparities hindering PrEP access. And we'll talk about these barriers in different buckets. The first one being structural barriers or systemic barriers. So when we think about these are large scale barriers. So high cost, lack of insurance coverage, limited availability of PrEP in rural or underserved areas, and then also, we'll put in this bucket inconvenient clinic hours and transportation issues. So, some of these, like the cost, insurance coverage, those are harder for us to affect change upon. For inconvenient clinic hours and transportation issues, actually, on a local level, specifically our clinic has tried to accommodate our patient populations by offering additional clinic hours later in the afternoon or evening, so for folks who work or go to school, they still have a chance to come into clinic later in the day. For transportation, we've tried to work with using our funding sources to, in certain cases, help our clients get to clinic when we know transportation is a barrier. So some of these structural barriers or systemic barriers are a little harder to impact or change, but some of them you actually can work on your local level potentially to navigate these. Provider level challenges, when we talk about those, we're talking about a low awareness or discomfort with prescribing PrEP or implicit bias in risk assessment and prescribing. And so we know from certain studies that providers do have implicit bias. And so I think it's really important that we provide education so that providers, number one, are more comfortable prescribing PrEP, but two, offer it to folks who really can benefit. And we'll talk about kind of some of those factors that make folks candidates in later modules. For socioeconomic and racial disparities, we know that there's lower access to PrEP among Black and Latinx populations. Due to prior or historical injustices, these populations have greater mistrust of the healthcare system, and there are fewer culturally competent providers than we would hope are present in our clinics. And so some of the things, we try to really provide like a very judgment-free, accommodating, trust-building relationship with our clients so that they come to trust us. We try to build rapport with those folks. And we can't single-handedly undo years of historical injustices, right? But we can build those relationships on an individual level with our clients so that we can try to chip away at some of that mistrust or distrust in the healthcare system. And then finally, the last bucket, stigma and misinformation. We know that PrEP candidates sometimes have fear of being judged or labeled. They have misconceptions about side effects and who PrEP is for. And so again, I think we need to provide education to our other providers, but also to our potential clients, that you know about the side effects or sometimes lack thereof, the safety and efficacy of PrEP, who it's for, and that there are ways to get around this like fear of being judged or being labeled, particularly with long acting formulations. And so we'll talk about some of that a little bit later.
No, I never felt no judge, no. But I'm just private with it, I don't have put people, in my business. I don't talk about it to no one. I don't associate with nobody. And then I never tell my family, no, 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 because I was really angry, when when he didn't tell me, so I kind of keep it to myself.
So PrEP uptake has improved over the past few years. However, it could be better. So the CDC estimates that 1.2 million people in the United States could benefit from PrEP. In 2022, 435, almost 436,000 people had PrEP prescriptions. So that's 36% of the population. And I will say that's a vast improvement from years prior, but we're just above a third. We're not where we need to be. And then when you look at who actually is receiving PrEP, there are incredible disparities based on race and gender. And so let me just show you this figure here. If you look carefully, you can kind of see the corresponding percentages. So, among the total population in the United States, Black people represent 14% of PrEP users, but they make up 42% of new HIV diagnoses. So that's a stark inequity among who is being diagnosed with HIV and who's receiving PrEP. And I'll say in the South, you could argue that this inequity is even worse. So Black people make up 48% of new HIV diagnoses in the South, only 21% of PrEP users. And then when we look at the United States as a whole, now talking about gender disparities, um, women make up 18% of new HIV diagnoses, but only 8% of PrEP users. So 92% of PrEP users are male, 8% are female, even though women make up 18% of new HIV diagnoses. So we have a long way to go into getting PrEP into the hands of those who need it most. And these disparities, as much as I am a huge advocate for PrEP and talk to PrEP about everyone I see, talk about PrEP to almost everyone I see who is a candidate, we know that PrEP potentially will make HIV disparities, racial disparities worse, right? And so we really need to try harder to get PrEP into the hands of those who need it most. All right, so now let's talk about current PrEP use in the United States based on different types of PrEP. So, just to kind of give you a little bit of background, we have two daily PrEP oral options, and we'll talk about populations who qualify for these different types of PrEP later on. But we've got TDF FTC, and that was approved by the FDA in 2012. And then we've also got TAF FTC, and that was approved by the FDA for HIV prevention in 2019. TDF FTC has been studied as an on demand PrEP, so event driven PrEP. And then long acting injectable cabotegravir, which was FDA approved in December of 2021. This is an every 2 month injection that's very effective at preventing HIV. Finally, I do want to mention lenacapavir. That has been studied in the Purpose 1 and Purpose 2 studies. Incredibly effective to prevent HIV. It's a subcutaneous injection given every 6 months, and that is slated to be reviewed by the FDA in June of 2025. So anticipating potential approval this summer. So now, if we look at the figure on the right, we can kind of see the different types of PrEP that are being used currently or over, the past decade, by PrEP populations. And so this blue line first is branded TDF FTC, and the green line that goes on is the total number of PrEP prescriptions. And again, this is over the past decade, but you can see, as we talked about, things have gotten a lot better over the past decade. More and more PrEP use, still not quite where we need to be, but you can see a steady increasing slope of that line, or increasing trend of the line. And then over time, over kind of the past 5 years, since TDF FTC has become generic, you can see a takeoff of generic TDF FTC as the branded TDF FTC is going down. And then starting in 2019, when TAF FTC was FDA approved, kind of an uptrend in that line too. Um, I mentioned that at the end of 2021, CAB-LA, or long-acting injectable cabotegravir, was FDA approved, and you can see it CAB-LA unfortunately makes up a very small minority of PrEP use in this country. It's growing, but growing slightly. So I think we have a missed opportunity, and a future opportunity, to get more folks on injectable PrEP, because we know, based on data from HPT in 083 and 084, that it actually is a superior method of PrEP, when we know that daily oral PrEP is subject to kind of adherence rates, right? So start talking about the MPrEP study for a second. This was implementation study, same day PrEP in Central and South America. More than 9,000 men who have sex with men and transgender women were studied. Mexico, Brazil, and Peru. This study enrolled between February 2018 and June of 2021. And I think this was a really important study, because I think same day PrEP is really something that we should be taking further advantage of. We know, we've actually studied this in our own populations in New Orleans, and when I was in North Carolina, we looked at this too. But when we do HIV testing the day that we see them in clinic, and we wait for that to come back, and we bring them back for their first initiation PrEP visit, several days later or a week later, there's a huge drop off in the number of folks who actually come back to that visit. Our data showed that half of folks, unfortunately, did not come back for their first visit. So really making the case for same day PrEP as a way to increase access and initiation. And so in this study, HIV incidence was 0.85 per 100 person years. It was higher for transgender women, those from Peru, younger folks, so those aged 18 to 24, those who identified as Black or mixed race, and of course, those who were non adherent to PrEP. And then transgender women, those with a primary education, again, younger patients, 18 to 24, were more likely to be lost to follow up and had lower PrEP adherence. So from this study, we can conclude that same day initiation of PrEP is feasible, but there are still really significant determinants of health, or these kind of barriers that we've been talking about, that need to be addressed in patient populations for PrEP use to be successful. And now I want to mention a study that was published in JAMA Network Open a few years ago, characterization of PrEP use among older adults in the Kaiser Permanente Northern California system. This was a retrospective cohort study looking at individuals who were 18 years of age or older who had received PrEP care between 2012 and 2019. And so, of all those that were in the cohort that were linked to PrEP care, 88.1% were prescribed PrEP, and of those, 98.2% actually initiated PrEP. And you can look at the 13,000 folks who are in this cohort. The table on the right gives some of their characteristics, kind of the breakdown of their age group, their race, sex, insurance status, alcohol use disorder, substance use disorder, and those having a bacterial STI within 30 days or a year prior of PrEP linkage. And so in this study, kind of similar to what we've seen, we follow this trend. Older adults, so those older than the 18 to 25 age group were more likely to be prescribed PrEP, initiate treatment, and maintain adherence over time. And then again, kind of disparities by race, right? So Black and Latino or Latina individuals were less likely than white individuals to be prescribed PrEP, begin treatment, or remain on it consistently. So the gaps in the care continuum were concentrated in populations disproportionately affected by HIV. This is a trend that we see in studies again and again, and kind of highlighting my point that we need to be doing more to reach populations who really we know are most affected by HIV and therefore can benefit most from PrEP. All right, so let's talk about the HPTN 083 and 084 trials. These were conducted several years ago. Long acting cabotegravir was administered every 2 months, and that was compared to daily oral FTC TDF. Um, and what I'm just going to kind of skip to the punchline here, but it was found that long-acting cabotegravir was superior to daily oral TDF-FTC in both of these trials. And ultimately, long-acting cab was approved by the FDA for PrEP in December of 2021. Now, moving on to the Purpose One trial, the results of Purpose One were published in New England Journal of Medicine last year. This was a double-blind, active-controlled, randomized phase 3 study. It was conducted in Uganda and South Africa. There were more than 3,000 participants enrolled, and this study had sort of Purpose One and Purpose Two, actually, which I'll talk about in a second. Both had kind of an interesting study design. So now, we have multiple daily oral PrEP formulations that are approved. We have long acting cabotegravir that's approved. We know that it's no longer ethical to do a placebo controlled study. They actually looked at baseline HIV incidence and compared that. The primary analysis was a comparison of baseline HIV incidence relative to lenacapavir. Um, but realizing that, which we'll talk about a second in the results, I just want to say the number of folks that were, or kind of the breakdown of actually how they randomized the participants. So it was 2 to 2 to 1, lenacapavir, TAF FTC, or TDF FTC. So they still did kind of 3 arms of the study, randomized. Again, all of these were actively controlled, and they followed folks in the double blind phase. And then once we had our kind of initial results of the analyses, opened it up for open label extension. And so here is the breakdown of the different populations. More than 2,000 randomized to lenacapavir, more than 2,000 randomized to TAF FTC, and more than 1,000 randomized to TDF FTC. You can see, again, this trial was adolescent girls and young women. So you can see that the median age was quite young, 21, in all arms. Again, conducted in sub-Saharan Africa. So primarily Black populations. And then you can see high rates of prevalent STIs among this population, low rates of any prior PrEP use. And while most of them had received prior HIV testing, it had been about 6 months since they had been last tested. And a requirement to enter this study was actually no PrEP use or no HIV testing within the prior 3 months. And what they found was in that the population coming in, the HIV incidence was actually 2.41 infections per 100 person years. Compare that to lenacapavir, 0 infections per 100 person years in this study. 0 infections really overall throughout the whole arm that was randomized to lenacapavir. So that was more than 1,900 person years. And then among the TAF FTC group, the number of infections was 2.02 per 100 person years. Among TDF FTC, it was 1.69 infections per 100 person years. And so, again, very exciting results. No HIV infections at all in the lenacapavir. And so the incidence rate ratio with Lin was significantly lower than the background incidence or the TDF FTC incidents. Now, to switch gears and talk about Purpose 2. So, this was again a randomized phase 3 trial, double blind, active controlled in men and gender diverse persons who have sex with men. And so this trial actually enrolled almost 3,300 participants. There was not a TAF FTC arm in this trial because we already know that there have already been studies, the Discover study that was conducted among cisgender men who have sex with men and transgender women, looking at TAF FTC in that population. So this was just lenacapavir versus TDF FTC. It was 2-to-1 randomization, similar to Purpose 1. They used a counterfactual study design. So they looked at baseline HIV incidence for anyone screening into the study. And I didn't say this before, but I should have. So the way they kind of characterized the HIV incidence was to use a recency assay to kind of determine when that HIV infection may have occurred among that group that was coming into the study. And based on that, they could calculate an HIV incidence.
When she told me I was able to be part of the study, I was super excited. And even though it was a mass study at first, so I didn't know whether my pills were the real PrEP or the injections were. And I went 2 years going through the study, nervous about which one was real and which one wasn't. And finally, I found out that it was the pills that I was taking all along that were the actual real thing. And it changed me in a positive way, only because I was then able to go out to the community and let my friends know that PrEP was not such a bad thing and that there should be no stigmatism on it just because it's not something that's going to hurt you. It's something that's going to help you, especially with those who are not honest and not have your best interest at heart and just want to do to you what they say was done to them and like just continue the cycle of negativity and bad things. And I was very grateful to be part of that just because the things that I learned through my journey was all positive and nothing negative, even though I forgot to take my pills once or twice and I freaked out thinking, oh, everything's over. But no, like PrEP is a really good thing. And I just want everybody to understand that there's nothing negative about it. And if you're on PrEP, you have a calmer peace of mind and you don't have to worry about those who don't care about your best interests and want to play Russian roulette with your life.
So, for the characteristics of the study population, again, you can see more than 2,000 participants randomized to lenacapavir and more than 1,000 to TDF FTC, consistent with the 2-to-1 randomization scheme. This was a slightly older population than Purpose 1. So mean age or median age, I apologize, 28 in the Lin group, 29 in the TDF FTC group. This study was very intentional. LSU was this site, so I know this firsthand. This study was very intentional about enrolling those who are most affected by HIV. And so there were certain goals to reach a certain number of transgender and gender diverse folks, and also Black and Hispanic or Latinx folks. So you can see sort of high rates of non-white populations in this study. Again, in order to enter into this study, the participants had to have no HIV tests within 3 months and also no PrEP use within 3 months. So you can kind of see high rates of no prior HIV tests here, and then high rates or I'm sorry, lower rates of prior PrEP use. And high rates of STIs at baseline, because that was one of the potential criteria for entering the study, and higher rates of stimulant use. Again, that was another potential criteria for entering into the study. And so here we can look again at this bar graph that's so impressive to me. The background HIV incidence being 2.37 per 100 person years relative to the lenacapavir HIV incidence in the lenacapavir group, which is 0.10 infections per 100 person years. And so, the conclusion is that lenacapavir is highly efficacious for preventing HIV. There were 2 infections. This was over 1,900 person years. So again, leading to that incidence rate of 0.10. And then you can just kind of see in the right top figure the incidence rate ratio comparison for Len versus background HIV incidence, and then below HIV infection incidence rate ratio for lenacapavir versus TDF FTC. And so the conclusion again, lenacapavir highly efficacious, reduced HIV infections by 96% versus this background incidence rate, and by 89% versus daily oral TDF FTC. For adverse effects in Purpose 1 and Purpose 2, what we're looking at here is injection site reactions. And I think the key thing to realize here is that there were, nodules seen, pain seen, swelling seen, but the green here is no injection site reaction. So what you're seeing in Purpose 1 on the left and Purpose 2 on the right is decreasing nodules, pain, and swelling over time. And so the green, where there's no injection site reaction, is actually increasing over time. So fewer injection site reactions as the study went on. Nodules kind of being the primary one. And I will say this is like foreign body reaction. This is a depot of medication. Injected subcutaneously, leaching out over time. So a nodule is not unexpected, right? And so, but the rates of these injection site reactions did decrease over time. So let's go back for a second and talk about some PrEP fundamentals. Pre-exposure prophylaxis, or PrEP, means taking antiretroviral medication before potential exposures in order to lower the risk of HIV acquisition. When taken as directed, PrEP is incredibly effective, and you'll see kind of slightly different numbers based on adherence or type of PrEP or, different factors, but we can generally say 99% effective in reducing the risk of acquiring HIV through sex. Um, the who is very important here. We talked in prior modules about stigma and really kind of only offering certain populations PrEP, which can be stigmatizing. The way we talk about PrEP to these populations, oh, you're at high risk of HIV. No one wants to hear that. So, what happened with the 2021 guidelines is the CDC actually said, hey, let's stop targeting different populations and stigmatizing them. Really, for anybody who is sexually active, providers should be having a conversation about HIV prevention, specifically PrEP, with those patients. And then they kind of laid out some guidelines for who is kind of we should be more intentional with, or who specifically is a candidate. And that includes have a recent history of STIs, do not consistently use condoms with sexual partners of unknown HIV status, and that is one or more partners, like not 2, 3, 4, one or more partners. So this is pretty much anyone who is having sex, particularly if you live in a higher prevalence area. I think you can kind of talk about that community risk. But anyone who is having sex, we should be having conversations about PrEP with. And then of course having a sexual partner living with HIV, if that partner is not definitely taking their ART as prescribed with an undetectable viral load. And then how PrEP is available as a daily pill, We could talk about 211 or on demand PrEP for certain populations and as a long acting injectable with cabotegravir FDA approved and lenacapavir hopefully to be FDA approved in the near future. Let's talk about of the approved and recommended PrEP populations, which populations fit which PrEP type. Okay, so daily oral TDF FTC, this one's easy to remember. This is everybody. Again, approved in 2012, lots of experience, safe, effective. We can feel very comfortable prescribing that as a daily oral pill to anyone who walks in our door who is interested in PrEP. For on demand 211, and we'll talk about dosing in a second, this is an off label use, but it is, I guess we could say, endorsed by guidelines as a potential strategy for men who have sex with men. And for some, some guidelines, IAS USA kind of incorporates transgender women and cisgender men, although it hasn't really been studied in those populations. But we do have good data from France and French speaking parts of Canada from the Abrogay study that 211 on demand, event driven TDF FTC is very effective for preventing HIV. For cisgender women or transgender men, this would be an off label, not necessarily recommended use of PrEP unless the risk is from anal sex only. Okay, for daily oral TAF FTC, we have currently that is FDA approved and guideline recommended for men who have sex with men and transgender men. I'm sorry, transgender women who comprise the participant population in the Discover study. Cisgender men are incorporated into that. And then TAF FTC would actually be considered off label or not recommended for cisgender women or transgender men. And kind of notably, TAF FTC was studied in cisgender women in the Purpose 1 trial. It was kind of not shown to statistically significantly reduce HIV infection compared to baseline HIV incidence in that population. Again, at CROI, there was kind of a secondary sub-analysis based on adherence. So we'll see sort of in the future what's to come for TAF FTC for cisgender women as HIV prevention or PrEP. But right now, its use would be considered off-label or not recommended. And then finally, long-acting injectable cabotegravir, FDA approved, guideline recommended for all populations. When we talk about monitoring our clients on PrEP, first we can talk about HIV testing. So we, of course, want to assess HIV status at initiation and follow-up visits. And so as of right now, the guidelines are suggesting HIV RNA assay is recommended and that should be done every 3 months with oral PrEP, every 2 months with long-acting injectable cabotegravir. I will tell you that we may anticipate a change in the future of that recommendation. There's more data coming out currently that the positive predictive value of RNA testing, specifically for those on CAB-LA, is very low. So that means we're seeing a lot of false positives, which can actually be like have a really negative impact on HIV prevention, right? Because if you think someone is actually testing positive, you're going to stop their PrEP. That creates a lot of emotional anxiety, but then also kind of makes them vulnerable or unprotected in that time while you're sorting out whether this is a false positive test or not. So as of right now, RNA testing, but potentially a switch back to antigen antibody testing in the future. For renal function monitoring, current guidelines would suggest that we check creatinine every 12 months with oral PrEP if the client on PrEP is less than 50 years and their estimated creatinine clearance is greater than 90 mLs per minute at PrEP initiation. If the opposite is true, so if they're age 50 or older or creatinine clearance is less than 90, that renal monitoring should be every 6 months. And then no renal monitoring needed with long acting injectable cabotegravir. And then for our folks who are on TAF FTC, we do suggest lipid monitoring every 12 months. So let's talk for a minute about PrEP use in pregnant or breastfeeding individuals. Pregnancy is associated with an increased risk of HIV acquisition. So this is actually a really important time that we should be talking to our patients about HIV prevention with PrEP. Safety concerns related to pregnancy and effects on fertility are barriers to PrEP uptake when um, those who are pregnant, have concerns about safety of PrEP, that is going to influence their decision to go on PrEP. So let's first talk about daily oral TDF FTC. It is recommended for PrEP during pregnancy and breastfeeding, and that is because we have really good data on safety and efficacy during this time in a person's life. So extensive use in persons with HIV, right? Because TDF FTC also treats HIV. We have good data from that. And then for PrEP too. So no evidence of teratogenicity in the antiretroviral pregnancy registry. Lactation studies in women with HIV suggest minimal infant drug exposure, and 5 completed studies report no difference in pregnancy or perinatal outcomes. So we can feel really good about TDF FTC in pregnant or breastfeeding women. And then I just want to talk, we have more kind of emerging data, preliminary data about the safety of CAB-LA in the setting of pregnancy. So the current kind of suggestion is if pregnancy occurs while someone is receiving CAB-LA, the provider and the patient engage in shared decision making, given kind of the limited safety data. And we know that CAB-LA has a long half life. So even if it is stopped immediately, it's still in the person's body for some time. So there was a secondary analysis of 084 that was recently published. No significant differences in pregnancy outcomes. Again, kind of smaller numbers, right? It's just a 084 analysis. But kind of no difference among those receiving CAB during pregnancy versus prior CAB exposure versus no CAB exposure. There were a few deaths in the CAB arm, but they were not determined to be related to PrEP. So now we will turn our attention to 211 or on demand event driven PrEP. This has only been studied so far with TDF FTC in this on demand fashion. What this means, what the 211 refers to, is that a person should take 2 tablets of TDF FTC 2 to 24 hours before sex. And then following the initial 2 doses, 24 hours later, take another 1 dose, 1 pill, and then 24 hours after that, or 48 hours after the initial 2 pills, take one more TDF FTC tablet. If sex keeps happening, then keep taking the daily pill, right? So it could be 2-on-1, but it could also be 2-1-1-1-1-1, depending on how long that person continues to engage in sex. TAF FTC, we don't, I think it's being studied, but we don't have data from TAF FTC on demand PrEP currently. So as of now, it's not recommended for use for on demand PrEP. All right. So interactions with gender affirming hormone therapy. So in general, most gender affirming hormone therapy does not interact with HIV medications. So we have some reassuring newer data that TDF FTC does not alter estrogen or testosterone levels, that there's no interactions between CAB-LA and gender affirming hormone therapy, and that it does not affect the exposure of daily use of TDF FTC or TAF FTC for PrEP. The current recommendation is that on-demand PrEP with TDF FTC should be used with caution in transgender women receiving gender affirming hormone therapy. And that is because there's a little bit of contradiction in the literature. Some literature saying that there may be, it may be influenced, and you need those more consistent levels. Some literature pointing that maybe you don't. And actually, the levels in PBMCs might even be higher in the setting of estrogen use. But I think because we don't have kind of that more definitive data and the on demand studies largely enrolled cisgender men who have sex with men only, we really need to use that with caution. And and as I have mentioned earlier, it's off-label use anyway. But I think one thing that I try to keep in mind when I am engaging with the patient in front of me, right, is a little bit of shared decision making and not to let perfect be the enemy of the good. So if I have someone who really does not want to take daily oral pill, is not a candidate for long-acting CAB for whatever reason, and they just want a pill and they just want to take it around the time of their sexual activity, and that's all that they are going to do, then we talk about the pros and cons of that, and we move forward with kind of the best thing that they think is going to keep them most protected. Okay, so let's just compare for a minute TDF FTC to TAF FTC for PrEP. Again, both very effective in men who have sex with men and transgender women. Um, TDF-FTC has been studied in heterosexual couples and people who inject drugs, while TAF-FTC has not. And then there are slight differences in kind of the renal side effects, the body weight side effects that you can see here. And in general, again, it's kind of the patient in front of you. If they have, they're an older person or their baseline creatinine clearance is lower, I'm going to kind of shift more towards thinking about TAF FTC for that person, but keeping in mind you lose that favorable impact on the lipid panel, and there are weight differences between the two of them too. TDF FTC is available generically and can be used off label for on demand PrEP. All right. And then let's think for a second about TDF FTC compared to long acting injectable PrEP. So in 083 and 084, both of the large clinical trials that compared these two head to head, CAB LA was shown to have superior efficacy relative to daily oral FTC TDF in both trials. Similar rates of renal AEs between groups, and then a little bit of initial weight gain in the CAB arm in 084, but the overall mean weight increase was similar in both groups. CAB LA is not available generically, and they both can be used non-daily. Obviously, CAB injections are every 2 months, and then we've talked about event-driven TDF FTC. So how can we improve conversations about PrEP? I think the key here is we need to normalize PrEP as a prevention option for any person who is or plans to be sexually active. And so just some key things that we can do here: avoid stigmatizing language, use shared decision making, as I've discussed, and then our clinic spaces need to be safe spaces for our patients, and we can hire staff members that are representative of the patient population, put up a pride flag, display pronouns on our ID badge. There are lots of little things I think that go a really long way to make people feel comfortable in clinic.
I would say at least start the conversation about, hey, I see that you're sexually active at this point. Do you want to think about maybe getting on PrEP? You know, one of my friends is HIV positive, and I find it that they do wish that PrEP was an option for them before they got it. But for me, on PrEP, I find that being with somebody HIV positive is not a negative. It's actually a positive now that I'm on PrEP.
And then one thing that we have found to be really successful in launching PrEP programs that have broad reach is having a PrEP champion. So really a person who can take on some of the challenges of PrEP, strengthen communication and leadership, be really proactive to try to again reach those folks who need it most, train others to prescribe PrEP, to have comfort prescribing PrEP, to reduce implicit bias, and all these things so that we can really meet the needs of our patients.
That the best thing about my whole PrEP experience was being able to go out to the community just to let everybody know how good of a thing PrEP is. And my friends were all jealous of me at first just because they wanted to be part of the PrEP study. And I told them that, well, you can still be part of the PrEP team by just going to the doctor and getting on PrEP. And you can advocate that way and still feel like you're doing something because it's a positive thing for the community. It's nothing negative. And enough people need to know and realize that their lives could be so much better and not, they don't have to worry or stress about who to sleep with and who not to sleep with. This way, you know that you're safe and everybody's safe. And it's a good thing.
And then we'll spend just a few minutes talking about the SEARCH trial. So, this is dynamic choice for HIV prevention. This was a study that took place in Kenya and Uganda. And really, this study showed that if we give our participants more PrEP options, that there's going to be greater uptake of PrEP. And so, we've known that this existed based on contraceptive literature in the OBGYN field for a long time. You give folks more choices for different options that suit their lifestyles, and there will be greater overall uptake. And so I just want to highlight real quick 56% increase in prevention coverage with this dynamic choice versus the standard of care. And so, what that meant was that the standard of care group had 13% PrEP uptake versus 69.7% in the intervention group. So that really large difference when people were offered choices. Um, and here you can just see the breakdown of what PrEP method they chose. No incident infections in this dynamic choice group. And so, kind of again, the punchline increased overall number of individuals who are using PrEP when they're given options, and when one of those options is cabotegravir.
So my primary care provider, they did not have an option for any kinds of PrEP at all. So she referred me to another hospital clinic that does provide that option. And when we were talking about it, she asked me about pills and injectables. But when I came in, I knew that I did a little bit of research before that I wanted to see if injectables were an option for me. Because the way that I work 7 days a week, some weeks, and it's 6 a.m. to sometimes 6 p.m. And to take a pill to make sure I have it on a certain day, every day, at a certain time, just would not work in my lifestyle. And I just felt like that would be an easier option, but also keep me protected.
Okay, so now we will cover briefly the Purpose One trial. So this was a double-blind, active-controlled, randomized phase 3 trial in cisgender women in Uganda and South Africa. This was a novel study design using a counterfactual model to look at the baseline incidence of HIV. So the primary endpoint was really HIV incidence while receiving lenacapavir versus this background HIV incidence. This study also included a TAF FTC arm because previously TAF FTC has not been studied in cisgender women. All right. And then the results were really exciting. 0 new infections in the lenacapavir arm relative to 2.41 infections per 100 person years in the background or baseline HIV incidence. Um, Unfortunately, TAF FTC incidence was not significantly different from the background incidence or the TDF FTC incidence. So I think kind of the verdict's still out on what's going to become of TAF FTC in our cisgender women populations. And here, this study was just presented at CROI earlier this year, looking at younger folks, so this adolescent group of young of girls who were enrolled into the Purpose One trial, and there were I think 124 total adolescent subjects enrolled in the study, 56 of them received lenacapavir, and you can kind of see very similar rates of AEs, a much smaller group. So the numbers are, of course, are going to be a little off, but really small numbers of AEs in this group. So arguing for the safety in adolescents for lenacapavir.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/CNQ860.